Hi, everybody. I think we're ready to wind up starting. I'm Al Shar from the Robert Wood Johnson Foundation, and I hope this will be an engaging session. I'm going to try and keep certainly my remarks to a minimum, but I want to quickly go through a couple of things. I hope this advances. Yeah. First of all, a little quick blurb in terms of who we are. Robert Wood Johnson Foundation is the world's largest, is the nation's largest foundation dedicated exclusively to the health and health care of all Americans. This work is done under the aegis of the Pioneer Portfolio, which is one of 7 teams at the foundation that looks to support those things that are both innovative and can lead to wind-up breakthroughs. So we're looking at spaces where there can be really major impact. Clearly, there's been a tremendous amount of excitement in this area. There's been a large amount of current and future investment. Shellmark Research predicted that by 2017 there'd be over $1.1 billion invested in this space, but according to IMS, 80% of that will focus on self-monitoring. The question that I want to ask us is there a sweet spot for the not-for-profit area, for the places where there is less than a market return, the place where we're driven less by financial gain and more by gain in health status? It's a question. We're still working on the answer. In October, we actually brought together a very small group of thought leaders to discuss this, to try and look at this as a premise. We asked Charlene Quinn from the University of Maryland School of Medicine to lead that effort, and she's here today to try and give us the key initial findings. Following that, we have a group of specialists in different areas that are going to speak toward their view of how we could work toward a more balanced portfolio. I said I was going to wind up being brief. I think I've done that. Charlie?
Thank you, Al. So the so this is the list of the panelists, and we'll come back to that in the end for discussion, so that you know what each one of us does. Do you want me to just introduce folks, or
Yeah,
just so we know?
Why don't we actually very quickly go through and have everybody introduce themselves?
So we have David Allen, who's director at Price Waterhouse.
Yes, that's correct. Working in healthcare strategy across a variety of spaces, but primarily in global health and health technology.
And Hillary Karazal.
Yeah, I'm Hillary Karras. I work at Public Health Allen King County, and I'm a communications researcher there.
And Dr. Alan Stiles.
I'm a senior vice president for U.S. healthcare systems. I primarily look at our affiliations and their development at this point, but I also have responsibilities for telehealth.
And Wendy Nelson.
Hi, I'm Wendy Nelson. I'm from the National Institute of Health, the Office of Behavioral and Social Sciences Research, and I work and coordinate much of the mobile health research that are supporting the field in mobile health research.
And I'm Charlene Quinn. I'm Associate Professor in Epidemiology and Public Health, Division of Gerontology. It all sounds like I can't hold a job because I'm here to talk about mobile health and became involved in this to look for opportunities where we could improve health, particularly in chronic diseases, using mobile applications. As Al said, we pulled together a group of about 15 thought leaders in the fall to help us address what should be the investment opportunities in mobile health. And if you can imagine bringing together thought leaders from some flew in for the meeting, cross country, West Coast, East Coast, etc., and fairly high-level people in each one of their areas that they represented, whether that was a healthcare system, National Institutes of Health, public health. So it was a great day. And one of the things, what we came up with was about 35 or 40 activities, if you will, or projects or areas that this group thought that foundations such as the Robert Wood Johnson Foundation or other nonprofit organizations might consider investing in to move the needle in mobile health. And from those 35 or 40 activities, you could really come up with several themes, and that's what we have in front of us. So the leading theme from this group, which was kind of appealing to me because I'm in the academic side, and I promise I didn't throw the data on this because we also had a good representation from the business sector, but there really was a strong consolidation of activities around developing evidence based on scientific research, that was a very high need, and that was the #1 theme. The second was to invest in activities that would translate to health system transformation. And we can get into the details of all of this in our discussion. The third theme that emerged was that there was a strong need for provider and public education about mobile health. What is mobile health? Why should we be considering it? What do we mean by mobile health? A number of activities fell into a category of looking at mobile health practice issues, and the other theme was provider and consumer engagement. Some of the investment opportunities, the specific activities that were prioritized by this group, the first one was to really develop a foundation of theory and evidence about what works. And we've heard that a lot throughout this meeting and other meetings as well. We have a lot of pilots, but not a lot that cuts across large amount of evidence. Secondly, and I think this is especially interesting given our panelists, and they'll speak to this, we really need to think through and describe the metrics for evaluating specific to mobile health. And that fits not only on the business side, but even on the scientific side. There was a strong interest in developing a strategic plan for mHealth and how it might impact health system transformation. And then another little task or activity which was fairly specific, maybe a little bit more narrow than some of the other activities, but to really develop a toolkit for health systems to build mHealth-enabled projects. So there's a lot of discussion about mobile health, but where should health systems actually take that investment? These other 4 activities, there was a discussion about accelerating digital health coach programs for vulnerable populations, describe non-traditional community provider roles, identify actionable data for self-care and for providers, and even some ideas about what about creating a mobile health blue zone community where people are focused on health and prevention, but from a mobile health perspective.
A couple of ground rules. What I try to do is each of our panelists now have one screen, and the easiest thing I think would be is to just speak from where you're sitting. The goal is to move as quickly as possible through these, not because they don't have a lot to say, they do, but because one of the drivers of this session especially is to help set an agenda. And we really want your ideas as well My goal from this is to, one, help Robert Johnson Foundation look and see what it might want to invest in. But I think we have an obligation to the field to look and see where that field might wind up contributing best to this space that's undergoing rapid and transformative change, huge amounts of investment, but with less of a focus, in my opinion, on improving health and health care, but more in terms of the focus on the specific gadget, on the specific item, on the specific activity. So with that, David?
Sure. So I'll try and be brief. I'm not great at being brief, but taking the takeaways across the bottom of that slide, I think we're all very aware in this industry that there is a plethora of different models, different ideas, different pilots, different devices, different levels of sophistication, and it's very exciting to be in the industry at this time. But I think where what we see as one of the biggest challenges from a consulting viewpoint and the kinds of problems that we encounter and try to resolve for our clients are all around consolidation, aggregation, and kind of bringing a greater degree of scale to the opportunities in mHealth. And I think fundamentally that's our challenge here. The other way of looking at the current versus future need is, I think there's a little bit of a risk that the market is starting to, this industry is starting to bifurcate into two pieces. One is very kind of consumer-focused mobile apps, relatively low clinical impact devices side of the market, and the other is very specific, relatively easy ROI stories in things like avoiding readmissions in CHF, where you've got a very specific high cost that you're avoiding and you've got a very specific clinical solution to it. And the challenge that I see, that I think what we need to do things on the right to avoid, is that those two markets could very well develop into one being on the institutional side a set of alternative approaches in a very small set of diseases where there is a very clear ROI, and on the other side you've got a consumer market that actually ends up being pretty impactful, but nowhere near as impactful in terms of actually changing health as it could be if those two sides connect. The way that we can get those two pieces to connect, I think, is in building and this kind of gets to some of the discussion that the rest of the panel is going to have, is how do we build a way of measuring the value and the broader ROI of mHealth with respect to patient engagement specifically. We have lots of proof points on the ways that individual devices and individual programs can change specific things like blood sugar levels or manage and avoid readmits. But I think what we're trying to look at is a meta solution that says patient engagement in general will deliver X for a provider, for a payer, etc. And that's the kind of goal, and that gets to the metric piece. Tried to be brief, failed. Are you okay?
I think that was quite good. Hillary? One of the areas that traditionally gets ignored and in general is the area of public health. The potential impact for good from public health is incredible. The lack of a public's knowledge of what public health actually is equally incredible. The potential for where mHealth can wind up leading is why we need to make sure we're paying attention to that. So, Hillary?
Thank you. Yeah, public health is community health, and the way we look at it is you're in the doctor's office a couple hours a year, you're in our office the rest of the year. So I think public health is important. I work at Public Health Seattle and King County in communications, and Public Health Seattle King County serves about 2 million people in urban Seattle, suburban area, and then rural communities all the way from Puget Sound up to the Cascades. So we have a lot of diverse communities. And we've been working in mHealth actually in text messaging for about 4 years, thanks to a grant from CDC to study how we can use text messaging to improve public health emergency communications. So we've been doing that for a few years, and I've talked with a lot of health departments in the last few years about mHealth, about mobile technologies, and about text messaging, and people are really excited, but there seem to be a lot of barriers to getting engaged. And I think, one of the key ones is resources. Our resources, public health is not now and never has been particularly flush. And our funds tend to be categorical in nature, and pulling dollars away from those categorical funding programs is really a challenge. And so that's why evidence and to know really what works and what is really going to be effective is all the more important in public health, because the resources are so scarce. We have done a few projects in text messaging around emergency communications and around text messaging people about immunizations, just as a way of getting our hands dirty and trying it. And sustaining those programs over the long term is going to be tough. So what do I think are some of the things that are needed? As I mentioned, King County is diverse. We have some of the really most healthy people in the whole country when measured by life expectancy and quality of life, but we also have some of the biggest health disparities in the whole country. So the difference between really healthy and our least healthy is huge. So we want programs, mHealth solutions to help bridge that gap. And we think that the return on investment is a healthier, more productive workforce, healthier, more productive people, and there's no money really to be made there, at least not by the taxpayers per se. But we think that low-tech solutions are really the way to go to reach our most at-risk communities because of access. Again, we need more evidence about what's really effective. We really need public and private partnerships, particularly around the technology, because I work at a pretty big health department. We have a pretty decent-sized IT department, and it's only been maybe 3-4 years since we moved out of Windows 97. So, really getting on board. We're not pushing the curve. Let's just put it that way. We also need workforce training. We have an aging workforce in public health. Sort of doesn't really understand what mHealth is to begin with. We need a lot of training of our workforce from school on. And then one of the things that I just wanted to mention, and we've been talking a lot about it with the Affordable Care Act and healthcare reform, how we're going to be working more towards integrating public health with clinical services, and how mHealth is going to play a role there is really exciting and has to be seen.
Thank you. Alan Stiles, as we mentioned before, is Senior Vice President for University of North Carolina Healthcare Systems. Question to you is, existing healthcare systems sometimes, or maybe often, get a bad rap for being particularly insular, working within themselves. Have you thought about how do you get mHealth to insert itself into that place where you've always worked by the tradition that you have?
I actually think that's an excellent lead-in question to this, and probably, if anything, it's going to be worse, not better, as we move along. I'm not going to answer the mHealth question for a minute, but let me frame a couple of things for you from my perspective. When you think about healthcare systems today, after the Affordable Care Act, or even before the Supreme Court's ruling about the Affordable Care Act, things went into motion, and they were very much in motion in a very practical way. Two big issues were being played out. One was consolidation, and the second was integration. And the consolidation had to do with buying up and bringing in multiple systems and practices, and from that standpoint, hospitals, other delivery opportunities under one umbrella. So you get bigger, and that was the goal. Bigger is better right now in healthcare systems. The second is not so obvious, and that's integrating the physicians and other clinicians and the hospitals into a seamless organization. For those of you who are clinicians or hospital administrators, you understand what I'm saying, and we were absolutely in two different camps, and they didn't necessarily overlap with each other, nor did they play well in the sandbox. So now all of a sudden we have to have a system where the two sides truly do work together. The second big thing to come into play with this is identifying a population to manage. And as you got bigger, part of the reason for getting bigger was to identify a population. The poorly stated way to put this is that we were trying to find ways to feed the beast. And the beast is really the hospital, because the hospital is the most expensive part of this. If it sits empty, then they're going to close their doors, and that's going to be a problem. So you need a very large population to capture enough patients to do that. This is not market share, and that fine point between population and market share is a very important one to think about as you consider this. The third issue healthcare systems deal with today is protecting reimbursement. Reimbursement for healthcare systems in general is on its way to at least Medicare rates. That's the common thought. That's a whole lot less money from the standpoint of being paid than where things exist today. But with more people insured, hopefully there's going to be some balance that will come into it. The real key is that pay is going to be made for value. And value is a very important term to understand as you think about this, because value should be looked at as quality divided by expense. So you can move value around by affecting different parts of that equation, and that's a truly interesting situation to be in. And finally, I would say the other big issue facing healthcare systems is the fact that their continuum of care had to be expanded to include all parts from pre-sickness all the way through post-acute care, and then this new term wellness, because we have a lot of well people out there. And to be honest, healthcare systems were built around taking care of illness, not taking care of people and their wellness. So we now have to rethink that. So please take that framework with what I'm about to say. I've listed a group of challenges here that I think are fairly obvious when one thinks about where mHealth may go in interactions with the healthcare system. One is skepticism. There's a lot of that in medical care, and it's not a surprising thing to say. I think most of our healthcare today would be viewed as episodic, and we have to move to something that will become continuous rather than episodes of care. Very different way to try to deal with patients. And fortunately, we have a young generation that has expectations to drive this, an older set of generations that don't know they should require this and will sit back and let it pass by. Reimbursement for mHealth is a complete unknown at this point, but the mere fact that we have companies that are for-profit out there doing things with mHealth suggests there's a way to do this. I can tell you healthcare systems have not figured this out yet, so they're going to sit on the sidelines for a while more because of that. And then there's always that underlying worry about how patients will behave about any new introduction of some requirement for them to interact. There is a very strong underlying concern that patients are not very compliant with what they're asked to do. There's also an understanding by the more enlightened people in medical care that this is probably because we don't communicate well with those patients. So this could be a means to get past that part. Tremendous number of opportunities, I think, from a healthcare system perspective. We have this move toward population health and wellness. Those two things are very readily apparent how mHealth might be beneficial in this way. Reimbursement about value could potentially be helped, because if we improve our quality or we reduce our expense of care, mHealth has the potential to reduce costs. That's a good thing for this equation. Patient-reported data gives us an opportunity to intervene at a much earlier point. That's been shown by home monitoring and other things that go on now around readmissions to hospitals, just as an example. Patients do gain some control, and that's something that most of us as individuals love to have at a point where you begin to feel helpless sitting in a physician's office. This is one way to take a little bit of that back. And finally, I think technology adoption has become less of a generational problem. My mother, at her age, emails and does things now, which 5 years ago she would never consider doing. And so, I think we're at a place where we've got some opportunity to move things along in a different way. So I'll stop with that.
Okay, thank you. Our last presenter, formal presenter, is Wendy Nelson from NIH. Wendy, there's clearly a need for a methodology to develop evidence that's based on scientific research, but it just transcends what the tradition is. What's the role for an expanded set universe of participants in this?
I think that's a great question, Al, and I think it builds on all of the things we've been talking about. As Alan just mentioned, there is a challenge of working with patient behavior. There's been a thing that they want. But what we all know in the research world, that 40% of preventable deaths is behavior. And we need to figure out a research base. We need to develop a learning ecosystem that can help us move behavior. And it's not just behavior of patients. It's behavior of providers. It's behavior of systems. And a lot of that is done on the fly. But we just had a session, and a really, really well done mHealth intervention, perfectly executed, had a zero effect. Very expensive, very well done, but a zero effect. So I think sometimes we think these things are self-evident, and we think there's only also one way to test. And I think we spent a lot of time at the National Institute of Health thinking about how do you evaluate, how do you think of that. We, in health, traditionally talk about the randomized clinical trial as the gold standard, which it is. But in a technology that's changing rapidly, how do we think about that? And also, how do we think about our outcomes? I think earlier we were talking about, there is a lot about engagement that we need to know about from all participants, whether they be providers, patients, or others. We need to know there's a science around that, and people have thought about that. If you look at the marketing world, they spend a lot of money in the science of how do you engage people, bring them into this. And we really need a science of that. I mean, we all got into mobile, or we all started talking about mobile because it's disruptive and it was going to change things. And my concern is if we don't start to build a learning ecosystem, that change will not be optimal, and it won't make the difference that it will. It'll be a minor change, and it may very well be a bifurcated system that doesn't realize some of the huge potential, especially in the areas of behavior, as our generation ages, as chronic diseases are increasing. And remember, this is not just a problem in this country, it's a problem around the world. Chronic diseases are increasing everywhere. And really what they take is this, I think, as Alan was just saying, it takes this long-term management, and it really takes a move to thinking about prevention and wellness from the beginning, but becoming a lifelong health consumer. And that's the potential we see for mobile, but we'll need to create an ecosystem where science, and it maybe doesn't have to be a capital S or a capital R research, the randomized trial, but that there's research built in all the time, in every way.
Thank you. This has been an exceptional panel. We were able to finish everything within a half hour. One of the things, and before we turn it back to you, one of the nice prerogatives of being the moderators, I get to ask one question. It wasn't one that was on anybody's particular radar, but currently in the system we have a set of well-defined roles that people wind up playing. Are there other actors that we, and I'll throw this up to anyone here, are there other roles, are there other actors that we need playing parts in this universe so that mHealth can wind up reaching its potential? Anybody? Yeah.
Yeah, but
Instead of doing the share.
It's not going to come out. Oh, it does.
Sure it is.
Wow.
Enough effort, we can get it out. So I would put forward that one of the more successful interventions that we've undertaken to try to improve on the management, particularly of individuals who have chronic illness over the last decade, is the introduction of care management to tie together the physician-provider, bridge into the community, and bridge to the patient. There are a limited number of care managers. They're very expensive, and they focus on only the worst, relatively speaking, of the problems that are out there. So if mHealth could be used to bridge these same gaps in a different way, perhaps, but in the less severe state, it would immediately generate a value piece that we've not thought about for the moment.
Oh, sure. I mean, I think to that question, I think we certainly see a large number of other players in this space, and lots of them are out on the exhibition hall and the social media side, from the telcos, consumer electronics, consumer retail. All of those different players are touching this space and see a huge value in it. I think it goes back to the risk of the bifurcated market that I kind of tried to lay out at the beginning, that it's a very attractive economic model, and if you're focused on it being another form of consumer media, another form of kind of getting consumers to play with gadgets and kind of learn things, and just kind of additional apps that have one and done kind of usage, that's a big market, and it's attractive to all these players. It's a kind of an opportunity for many of the types of company that I'm talking about to say, we've done something, we've kind of made a real inroad in this space, and we're interested in helping the consumer and pushing for more sophisticated healthcare and driving down costs, because ultimately, if it doesn't work, they're not going to lose anything from it. They're going to get still going to have all of the benefits of having sold multiple more devices, sold much more apps, sold much more bandwidth, but without necessarily changing people's actual healthcare behaviors, which is what requires the other side, which is so focused on where's the things that I can actually reduce my my hospital's bills right now, where are those specific pieces where I don't necessarily need all the other proof points, but I can get an economic argument, or there's a kind of a clinical efficacy argument that I can tell. But it's all of the challenge is that side of the market has a serious issue with scale, and that I think gets to kind of what we're all talking about. We really want a market that has scale, and that's the elusive thing, because it's in the middle between the two markets that we're playing with.
That was it. That was mine. So,
Okay.
I would just add one thing, a little bit different perspective, is that I think to really work in the community with some of our most ill people in our communities, we really need to engage community-based organizations, people who really work with communities every single day and know the communities, know the audiences, and can really be really good partners in developing mHealth solutions that are really going to work with our diverse audiences.
Does anyone on the panel have a burning issue that they want to mention now? Because if not, what I'd like to do is give the audience an opportunity to make whatever comments they want. If you guys don't, we'll keep talking. And believe me, I know most of these people, and they can go on all day. So if you do have a question, please step up and identify yourself.
It works? Okay. Hi, I'm Zorina Gallus also from the National Institutes of Health, one of the many institutes. And my question to all of you is, what do you think the role of the government should be in this revolution? I have my own opinion, but I would love to hear yours. Thank you.
We can't let it.
Okay, so, not speaking from the National Institute of Health, but as a member of the National Institutes of Health, I think that there's a lot of roles that we can do and enhancing what's happening out there. NIH is now involved in building a public-private partnership in mobile health, trying to bring together some of the amazing things that's happening in the private sector with our scientific community to really have them both enhance each other. Also working with the regulatory agencies, also working with CMS to bringing everybody together into a space that they can start to we don't take advice, but we love information in the government. So really making an environment where we can work together to learn that. I mean, at NIH, our goal is to really enhance the science here, whether it's the capital R research. But I mean, I think that helps us optimize where we're going to end up.
One of the things that through this project and through other work, I think an important role of government is to help us define what the metrics are for evaluating mobile health. It's been helpful. This is the first time in this space where we started talking about, what the randomized clinical trial is a gold standard, but it might not work for evaluating mobile health. And it's one of the things Dave and I were talking before we started this session. If you'd come to this meeting 2 years ago, you wouldn't have seen the use of the term patient engagement or engagement as much as we have now. And Wendy, you and I have had conversations about, wouldn't it be valuable to have a primary outcome of a project be engagement, not necessarily change in hemoglobin A1C if you're looking at a population. So I think there's a role for government to help us define those metrics and help us build the evidence, because that evidence then feeds into professional guidelines, which then get translated to what healthcare systems and providers then may use.
I'll mention a concern that there are more and more different agencies within our government who both need to and are taking a more active role in looking at the regulation of this space. On one hand, I think that that's good and important. On the other hand, I get concerned to make sure that those agencies actually do wind up talking to each other to make sure that they work in concert with each other. There was just a bill put forward to have a separate division in FDA focused on mobile health. I think that that's a good and important issue. I worry about whether or not the funding is going to be there for them to do the kind of job that's really needed. So I think that there are lots of issues.
Hi, Evelyn Chereau, and I'm CEO and founder of a social enterprise that functions as a public-private alliance in mHealth, focused on developing countries. When you opened, I may have missed this, but I heard you ask the question about the role of the nonprofit. And for those of us in the social enterprise space, even though we don't have an official tax code designation yet in the U.S., the state of Maryland has identified B corporations, benefit corporations, and LC3s, and I can't remember what that stands for, but similarly for those who are trying to apply business principles for social good. So I hope that you're including the 2,000 people who show up at the Yale Global Health and Innovation Conference every year who consider themselves social entrepreneurs, and that the Skoll Foundation and Stanford Innovation thinks about as perhaps developing hybrid models and where they fit in what you're talking about. But I also wondered if you mentioned the toolkit that you think is needed, and I'm wondering if you looked at the World Health Organization toolkit that's being used by countries around the world for developing national e-health plans. And if you've been considering meta-analyses of all of the grants, for example, for those of us who spend our lives writing grants for USAID and having to develop monitoring and evaluation, even State Department, has very structured monitoring and evaluation requirements. So have you thought about that aspect? And lastly, I guess, the American Telemedicine Association has a number of special interest groups that are developing white papers on best practices, and are you looking at some of the work that's been done in telemental health and pediatrics and the technology special interest group there and some of the work that they've already been doing in this space? And lastly, I like to think about the impact investors as the other groups that we're trying to engage, who are asking about what's the return on investment in this space for developing countries. Thank you.
Let me do a quick clarification about when I was talking about what space that we were looking at, and what I meant to wind up saying is looking at those agencies other than looking at direct return on investment as the metric. B Corp, the whole social benefit areas make absolute sense. We're looking at how can those sectors best invest to move a field that's moving very, very quickly forward in a way that has measurable and beneficial outcomes.
One response to that?
Yeah.
There's one thing I think you're really bringing up that's really important is not duplicating. I think there is, I was just having a conversation with my colleague at USAID about how do I learn what he does. We work together in our public-private partnership, but I think we're now coming together in forums like this to think what is being funded in the actual biggest funder of mHealth is the World Bank. And people don't realize that. We don't have a record. We don't think about that. It comes out in the gray literature and all that. But so the government is starting to come together saying, how do we partner? How do we move? How do we think? How do we make sure we're leveraging each other's investments?
So let me comment. First of all, I'm a pediatrician. So I've lived my life without evidence and practice that way. And we've done a little good in that process here and there. Government requirements for studies have always been an impediment rather than help around children's issues. This in some ways has a similar feel to it, to me. Not being a researcher in this area, I can talk about that. In fact, in my early days, my children referred to me as a rat doctor, so I did deal with a little bit of more basic, very structured research. And now in later times, I'm much more interested in how you change whole systems of care, literally at a state level. And that's a very different process, but holds some of the same things. But the idea that we have only one way to get at information, I think, is important. And so I want to ask a question of the group. I've been dying to ask this question because I just ran across this dab of information. How many people in here from Maryland? Just, okay. So maybe you should recuse yourself from this question. But who knows what the official state sport is in Maryland? Yeah, I know you do. All right, so this is one of those worthless bits of information, but you gather it from unusual sources. And I've made this point over and over to house staff when I teach them. You have to listen to all the sources. So it's jousting, of all things, to have as a state sport. So that comes from a Snapple cap. And, you know, I've got all kinds of Snapple cap important data to give to residents when I talk to them. But the point being that there isn't only one way to get at the end of the question and get something important from it. So there are other ways, and we need to consider some probably unique and as yet untried ways. Meta-analysis, certainly a tool that's begun to be used more, but there are lots of ways to do things and investigate and have some scientific validity at the end. But we need to think about that on the front end. Otherwise, we're going to end up with something that becomes part of practice without ever studying it, and that is a bad way to get somewhere.
Can I just add one? Just one quick point on the. So no, no, I totally support jousting. The quick point on the toolkit question is I think one of the things that doesn't necessarily always make its way to the top of people's minds when we're thinking about mHealth investment is that arguably in this country now the challenge is as much a project management challenge as it is anything else, because you're getting out there and I think you'll probably find that with the text messaging side of things as well. You know, the challenge of multiple different physicians, multiple different payers, multiple different systems is, yeah, maybe it's a little bit more complex in this country than it is in other places, but that recognition that any vendor or any government-sponsored structure providing all these services is going to have to go through a lot of pain to make it actually work for the end consumer that's using this and gets a benefit out of it, I think is something that needs to be, you know, and I'm not trying to kind of stick a spanner in the works, but just real emphasis on that project management need as part of the toolkit. I don't know whether it's there. I need to go look.
Yeah, Roger Glass from NIH and the Fogarty International Center. I just wanted to refer to Alan's slide up there of the problems with mobile health there, one before there, the challenges. Because all of those challenges, as I looked at that list, skepticism, concerns, behavior concerns, all of those are addressable by research. And without the research agenda, we're going to be standing with the same challenges. Also, many of the challenges, I think some of the research really provides low-hanging fruit. I have a mother who's in congestive failure all the time, easily monitored by a scale. And I can call her up or I can have her scale call me and tell me when she's up or down, and it keeps her out of the hospital. That's something that's so costly as a hospitalization and so cheap as a scale monitoring daily weights that it seems almost trivial to be able to gather the evidence to document the health care savings for that event. So I think there are numerous, whether it's in pediatrics or any of our care, where that research properly done, and not expensively done because people have the devices, but properly done, could really make a huge difference in this field and erase all of those challenges and move them into the opportunities column. I think that's my interest in the global health, not only domestically, but on the international scale.
Anyone else?
Mark Wine, I'm a director in the Price Waterhouse Federal Health IT practice. Right now there's a disconnect of lack of interoperability among all these mobile apps. It's about the data at the point of care and using it meaningfully or with just clinical decision support across a continuum of services for the patient. Can you say a word in brief about a methodology, a rational methodology that can be applied to determine the best mobile health, let's say, innovation application as a path prioritized for deployment at the points of care that will most help the cost of healthcare delivery, the quality of healthcare delivery, as well as in a prioritization on the timeline of evolution of transformation here, most importantly, the communication between the patient and the provider. A rational methodology, how are we going to sort all this out to determine what are the health IT innovation trends, and what are, then within those macro trends, what are the best, more specific health IT innovations to begin to deploy in institutions and with people.
Can I take a shot?
Sure.
I think this implies there's a solution, and I don't think there is a solution, but I think we can systematically look at topics like engagement, because engagement leads to a lot of other behaviors. I mean, in health, diet and activity, physical activity and diet are two of the hugest drivers of almost all of our problems. If we looked at smoking, so we can, and if we can think about those in different populations, can we find the optimal solutions for, and it might be something as simple as 18 to 24-year-old males. It may need to, we may need to find these pocket populations that are, are at high risk and susceptible, and tailor to those. But I think it's figuring out, I think we need to really systematically look at who we're targeting, what we're targeting, and we can target some of the big things. I think, this bifurcation, I think it's a really good point. Because some of the things that really save us money are the behaviors. And I mean, I must say that diet, physical activity, smoking, and drugs and alcohol, are the big drivers. And depression, mental health is one of the biggest drivers of missed days at work. It increases our cost. And these are the things we can look at. These are the big drivers of things. Instead of, rehospitalization is critical. But if we really step back and think, what are these big things that are affecting us in the wellness arena? Maybe they're not driving us to the emergency room, but they will eventually. So,
I also heard in your question something that spoke to interoperability, to the ability to wind up taking separate applications, separate interventions, and being able to wind up combining them. One of our grantees, and actually a competing session right now, is mHealth, which is looking at a way of architecting applications to allow for the one building upon another, the sharing of data through a shared set of standards. You also have the commercial platforms that are looking to wind up doing that, Qualcomm, AT&T. So there are things that are going on. It would be great if there was clarity in saying that there was exactly one solution. There's not. But there is activity that's going on in that space.
Yeah, I was just going to say, I think there is not PwC answering a PwC question, but from a methodology standpoint, obviously there are lots of different pieces to that, from looking at the diseases themselves, looking at the populations, looking at what kinds of disease states are amenable to some form of mHealth solution that actually creates a significant change in outcome or whatever it is. The problem is that every time you try to do this, it depends who's asking the question. Because if you're asking the question from a telco perspective, you'll get a very different answer to if you're asking the question from a payer perspective. Sometimes all of those things meet together, and CHF, lots of people have mentioned multiple times, because that's the one that hits everyone's buttons, right? That's the one where there's a clear interest in it from a provider standpoint. There's a clear interest in it from a payer standpoint. There's a clear interest in it from the vendor standpoint, because it's something they know they can solve. It's a simple, not a simple fix, but it's simple to monitor and get some value out of it. If you go through a kind of a prioritization, though, below that you very quickly start to get different answers for different disease states, for different demographics, for different group populations that are funding this, whether they have an interest in it. And that's what I think leads to the bifurcation. There's very few things at the top right-hand corner of that chart and millions of things at the bottom left with lots of different value propositions to support them.
And if I could just add one other thing, I think one of the really serious practical issues that is dealt with on a day-to-day basis by clinicians is an overwhelming amount of data. They have very little information, but they have tons of data rolling in. This is arguably a reason mHealth may be more of a problem for clinicians and less of a solution. I don't really believe what I'm saying right now, mind you, but I'm just putting it out there as an issue that you have to think about this, because if you think about home monitoring as one example, someone has to look at the values being reported from home monitoring. The likelihood of that being a physician sitting down and looking at the EMR and looking at the 20 or odd patients they may have at home on home monitoring is pretty slim. They need someone else to do that because it interferes with their workflow. And at this point in time, physician workflow is the one sacred thing that can't be screwed up in any of the things we're doing. And we've screwed it up with EMRs. We will screw it up with other things that have to do with technology because they inevitably don't save time but take more time. And then the third issue is that there are now just buckets of additional data, information, new knowledge out there that can't be incorporated in any single human's head in a way that they can make use of it. So the decision support tools have lagged behind the point where these monitoring tools are out there giving us data back. So we're in a sense at one of those points where we have something that's really good, perhaps a step or two ahead of where it might be, that we have to be careful that we don't lose in the process of studying and figuring out.
By the way, that's one of the spaces where I see one of the major lack of investment in this space, and it's, you know, more broadly, it's how do you improve the communication between an individual, a patient, and a provider, someone who's charged with taking care of them, especially in a space where the bandwidth for the human bandwidth has to wind up being limited. I see us building more and more and giving you more and more things that you need to wind up looking at without giving you any time to look at that.
Oh, that was one of the things. I don't know if you all remembered it from our meeting at Princeton, and that's why that point on the slide about investing in things that provide actionable data, so not only for providers, but even for patients or persons, if we think of persons in terms of health promotion and getting to issues before they're sick. So not just giving people data back, but give it in actionable formats. And so I'm sure there are some companies, there are health IT people who talk about developing algorithms, systems that learn, et cetera. So that was pointed out as an investment opportunity.
Before I get to anybody's questions, I notice that people may wind up leaving. I mean, this is not an encouragement to leave. But if you do have ideas, please write down my email address, send them. The goal is to build an agenda for the field, whatever that actually winds up meaning. And I do mean the field as broadly as possible. And your ideas can only wind up helping. Okay, thank you.
Sure. Hi, I'm Jessica I'm at the University of Michigan, their School of Public Health, and I'm particularly interested in where the private sector intersects with public health. So this is a very interesting space, and I see that we have kind of on a very large level, you've got a lot of big players that are active, particularly within this space. However, I'm not really sure that public health is engaging correctly with entrepreneurs. I was in a similar forum like this yesterday with entrepreneurs looking for funding, and I asked the question of, well, you're all talking about the ROI and the return on investment, but what good is it if there's no health outcome associated with it, with the product? And so I do agree that on some hand, I think, and with my public health colleagues, I speak to them and I say, oh, that's a great idea, but how are you going to sell it? What are you going to do with it? How are you going to get that beyond your research population? So I guess, are there tools out there that link researchers within these behavioral interventions to entrepreneurs or to companies that might be willing to help scale out these projects? And how are we really thinking sort of forward about that beyond just sort of the really granular kind of macro level, but at that micro level?
So, hey, we're doing that. No, I mean, this is why we're doing a public-private partnership. The first thing we were asked for was eHarmony. To build a world where industry and science could come together in a meaningful way. I'm not going to build eHarmony, but what we're trying to do is build a forum that people can communicate and to get to these things. Yeah, eHarmony, the dating service. No, I'm not going to do the mHealth dating service, so don't say that. But it is building those forums, and I think there's, and it's not just us. I mean, I think that's. The Wireless Life Science Alliance has been thinking about this too and trying to build out systems, and it will take effort from multiple players on how to do that.
My name is April Bragg. I'm with Centerstone Research Institute, and we're the research arm of one of the largest community-based mental health providers in the U.S. We actually have a session tomorrow, and so many of these topics are ones that we are really focused on. We actually at Centerstone have been doing clinical research in mental health for over a decade, and we've reached out, thanks to local foundation funding, to other mental health providers across the country that are research-oriented to form a collaborative. And so we have this terrific collaborative. We're doing predictive modeling, data mining, and a lot of these themes. And I really respond and just thought your point was so important around community organizations and reaching out, because that's what, and that's what we're doing, actually, the previous question as well, like just reaching out to other sectors and how do you bring people together, because folks are, kind of operating in their own spheres, and that's where the bifurcation can, I think, explode as well. But what are the incentives for both private and public organizations to seek out partners in community organizations or, other areas that, other organizations have filtered into and have additional resources that, when you can combine them in a partnership, can make a much bigger difference in terms of answering these questions and scaling these issues. So.
It may not be the answer you want, but that from a commercial vendor perspective, that's exactly what they need to do. But that gets to that project management and kind of broader toolkit discussion, because a lot of the commercial vendors of mobile health solutions realize that there's only so much value in having a device, software, algorithms, and a call center. You need all of the other touch points in order for you to essentially get referrals into your program. So I think there is an incentive on the private side purely from making the business work. That means touch points have to get as broad as possible to bring as large a volume of people into a commercial model beyond a pilot. So I think we see that. I don't know if that's what that helps or not.
We're also seeing that starting as the regulatory framework starts to clear up, that people are saying, I built this really cool thing, but I have to try it on real people. And real people are in the community, and so, I mean, they're starting to reach out that way. So.
I'm sorry, this has been the best session for question time, so I really appreciate that you've given us this forum. I wasn't sure I saw on the list that was initially discussed healthcare workforce shortages and that priority, and I'm wondering if you had the discussion about task shifting and whether we're actually, as we are in international developing countries, obviously, to community-based health workers, but I'm old enough to recall the Kellogg move to multi-skilled professionals in this country that those of us who are professionals fought that movement because of licensure and certification and accreditation of grad schools and all the things that we do as professionals in this country that creates the walls that really interfere with technology and across-state kind of portability and things of that sort that we're all trying to address now. But for developing countries, obviously, this whole issue of healthcare workforce shortages that will never be addressed with enough professionals, that we certainly are now realizing how important it is to have economic empowerment of the community-based health worker and look at other types of professionals. So I'm wondering what your discussion was on workforce.
We did talk about that at our meeting of the thought leaders. It just wasn't real high on the list, and I sort of grouped some of those themes together when I talked about education. But that was clearly one of the activities that we might even support a definition of a different community worker that would use mHealth or mTools partially to fill gaps between providers or between providers and patients or family members. So that definitely was on the list.
Does anyone on the panel have anything more to wind up adding? Okay. Well, thank you all very much for coming. Again, ideas, things that will make this work are really important. And we do wind up appreciating your ideas. Again, thank you for coming.